All right. Thank you. Good afternoon, everybody. I'd like to thank you for joining our educational series for the month of April. This afternoon, we're going to be talking to Eileen Warden and Caitlin Scheibel from the Michigan Department of Health and Human Services. Eileen is the state trauma manager, and Caitlin is the department manager for systems of care. Today, they are going to talk to us about the updates for stroke and STEMI. So Caitlin and Eileen, welcome, and I will let you guys take it from here.
Thank you, and thank you everyone for taking time out of your day to join us. So we'll walk you through the updates for stroke and STEMI systems of care. I just need to make one adjustment real quick. There we go. The mission statement for the Michigan Department of Health and Human Services. And we'll get started with a brief introduction to understand who I am and my role. I'm the department manager for systems of care for stroke and STEMI. I work in the EMS section under Eileen Warden, who is the systems of care section manager. I'm a paramedic. I've been so since 2005. I have a bachelor's degree in healthcare management, an MBA in healthcare leadership, and my healthcare career is starting to encroach on about 25 years across the continuum: skilled nursing, hospice. I was a dispatcher for about 5 years. And I spent 11 years at a large academic healthcare system working in emergency medicine and with a critical care and hospital transport team. Eileen, did you want to introduce yourself?
Sure. My name is Eileen Warden. As mentioned, I am the Systems of Care Manager. We just took on that title when the administrative rules and funding passed for supporting systems of care for stroke and STEMI that will fall under our division of trauma, stroke, and STEMI and EMS. We're in the Bureau of Emergency Preparedness, EMS, and systems of care. I've been in the role for 11 years. My background is a nurse, and I'm excited to talk to you all about the plans we've got in place and are preparing for to operationalize systems of care for stroke and STEMI. So thanks for having us.
All right, our objectives for today are to understand the background and history around systems of care, review the components of the administrative rules for systems of care for stroke and STEMI, and understand Michigan hospitals' role in systems of care. Now, the discussion around systems of care and the work to implement them has been occurring for a long time. For more than 25 years, heart disease, stroke, and unintentional injury have remained in the top 5 leading causes of death in the state. The recognition that time is muscle for STEMI, brain tissue for stroke, has been acknowledged by experts in the field for more than 18 years. And the Sentinel papers by Alice Jacobs and Lee Schwamm outline how systems work to improve efficiencies and outcomes. And we will be sharing the slideshow with you. The last slide has links to those papers if you have an interest in reading them. The current initiative builds on conversations that have been ongoing since 2011 and the foundational trauma system that has been in place since 2012. Work groups made up of subject matter experts from around the state helped draft the white paper, which is published on our website. It's called A Statewide System of Care for Time-Sensitive Emergencies, the Integration of Stroke and STEMI Care into the Regional Trauma System. And they've also helped with the components of the administrative rules for both service lines. And ultimately, the vision is an integrated system of care for time-sensitive emergencies that includes trauma, stroke, and STEMI. These systems of care incorporate a variety of disparate health care components into a formal structure that's established, supported, and supervised within statute, administrative rules, and policy. A look at what systems do. Systems give you a chance to interact in a formal way to improve care for your region, neighboring regions, and the state. They allow us to categorize resources, decreasing animosity around what level of care is available, and helping pre-hospital providers make informed decisions about patient destinations. In the case of rural health, this translates to capitalizing on smaller hospitals and facilities to stabilize when necessary or treat and manage, lower acuity patients. Systems give us processes like performance improvement, as well as regional infrastructure that empowers stakeholders to review, monitor, and engage. to improve the delivery of care, patient movement, and to reduce incidence of injury and reduce cardiovascular risk factors. Systems also help us to eliminate silos and encourage sharing of best practices and cutting-edge thinking, not only locally, but across the state. Systems allow us to collect data on a larger scale and utilize the results to drive decision-making, affect change, identify gaps, plan initiatives, and monitor their impact. And lastly, systems facilitate relationships that cross boundaries, eradicate silos, build partnerships across service lines, facilitate regional specialty group departments and special interests. When you talk about the phases of systems, they exist on a continuum. They cycle through the phases from prevention to ongoing care and rehabilitation, and the components of the system are intended to improve care and outcomes through evaluation and change in each of those phases. The systems of care section is focused on developing systems of care for all 3 time-sensitive emergencies with the goal of working with partners and stakeholders to move the needle towards reducing the number of people in Michigan that are negatively impacted by trauma, stroke, and STEMI. Building the integration plan is centered around the existing system pillars, which are data and registry, designation verification, regional organization, education, and advisory bodies. We are looking at how to initiate these pillars for stroke and STEMI based on what has already been created for the trauma system. We have to consider what order makes the most sense based on what's already established and what the needs are for stroke and STEMI programs. And when we look at those pillars for each service line, there's been a lot of evaluation of what is the next right step. And sometimes when we come together, that changes every time we have conversation, but we are constantly evaluating, reevaluating, and looking at how to move forward in the best way. And you're going to hear me use the term integration a lot. It is important that each service line feels like it's seated under a bigger systems of care umbrella rather than 3 siloed service lines. Well, the implementation plan is centered around the answers to these big questions. We have a wealth of inputs, including reports from the initial work groups, the trauma system, the foundational papers, the NHTSA report from their evaluation, the Michigan Stroke Program, the HRSA documents, Michigan Medical Control Authority assessments and protocols. We have to think about what needs to be created. There's a lot of work to develop outputs, and this is where stepping it out in a time-wise fashion is the only way to keep it all straight. Certification crosswalks are underway, education assessments, looking at the org chart and the regional structure, Michigan criteria for designation, and making sure that stroke and STEMI aligns with what we're asking for trauma as well, and a lot more. We've also considered initiatives that are necessary to support the work of programs, including injury prevention and risk reduction, system education. We are participating in the EMSC's patient movement ad hoc to approach that from a systems perspective, and we're seated on several national committees as well. The Division of EMS and Systems of Care is committed to successful program building. It's what has been successful with the trauma system, and we'll continue it with stroke and STEMI. We have learned that standing up the trauma system has affirmed that the process for system building isn't linear. Timelines have to flex based on inputs, both internal and external, some of which we have no control over. But we will deliver updates and communications as things become more concrete, and we are committed to sending out information with plenty of lead time to allow stakeholders and partners to prepare for next steps. So we'll move into a little conversation about the administrative rules. The administrative rules really act as a blueprint for operationalization. If you think about a construction project, this is the big tube of blue and white paper that shows us where we're going to put walls and hang lights. They're a guide for standing up the system pillars. Each service line has its own rule set. Stroke and STEMI are both 13-page documents that were modeled after the trauma rules. The administrative rules define how to implement and operate systems of care, as well as the role of the department and regions. They also define verification and designation of stroke and STEMI facilities, and they provide the basis for data and registry requirements, set standards for regional performance, and offer considerations for destination protocols and interfacility transfers. And the bigger question is, what's the role of Michigan hospitals and systems? And based on the blueprint, these are the 4 key components the hospitals can contribute to systems: risk reduction, performance improvement, designation, and data. And we're going to take the next few slides to break this out and talk more about this in detail. So we'll start with risk reduction. It looks different depending on the community. You know, the needs of the rural communities is very different from what risk reduction might look like in southeastern Michigan, where it's very urban and the population is different. Much like injury prevention, risk reduction programs can be built to address community-specific issues. A lot of this is already going on in the form of blood pressure screening, education about early detection of signs and symptoms, and early activation of EMS are some of the options. Many programs have started partnering with community organizations or healthcare coalitions to increase reach and share costs. And we acknowledge that this is something that you guys are likely already doing, and it's just a matter of formalizing the process. And the same with performance improvement. This is something that hospitals are already doing, looking at case review, closed loop feedback, and evaluating processes. We know that performance improvement is a critical part of systems. This is the process that allows providers to assess what is working well and where gaps and barriers exist in the continuum of care. And, you know, it kind of happens in spheres within a facility, within a region, within an MCA, and moving out. In case review and closed loop feedback to EMS providers can lead to process changes, educational opportunities, identification of risk reduction targets. Sometimes it's a matter of evaluating, you know, tasks and whether or not they can happen concurrently or consecutively, and how can, especially in the case of stroke and STEMI, how can we streamline time processes to get patients where they need to be and to ultimately seek treatment and get back to their lives. And this is the big question everybody has around the designation process and what it's going to look like. Designation status is based on a process developed and operationalized by a state. Only states can designate. In Michigan, designation is completed through an application and verification of certification or accreditation by a nationally recognized professional review organization, as well as meeting Michigan criteria. The process is voluntary and inclusive, and we want to say that again and make sure that this is the big takeaway for designation. It's voluntary and inclusive. It's intended to be available for any facility who chooses to seek designation. The level of certification or accreditation a facility seeks is based on their own individual resources and how they align with standards of the review organization they're working with. So there's a lot of questions about how it will work. Facilities will assess their current level of care and appropriate match to levels described. And again, the system is designed to be voluntary and inclusive, and it is most effective when all of us participate. As previously mentioned, the department is invested in successful program building, and the system is designed to be most effective when everyone participates. With that in mind, once we open the application process, it will remain open. There will not be a window or a deadline. We understand that some programs will be ready as soon as we offer the ability to seek designation, while others need time to prepare and build programs. The trauma system has shown us that the process is very fluid. There are still programs that are working towards initial designation. Others have adjusted their level of care to match organizational changes. And some have chosen to abstain for now because they're just not ready. The system is intended to meet you where you are. The rules specifically state that the department shall not limit the number of facilities that seek to qualify for a given level of designation. So what does that mean? That means that whatever level of designation your facility aligns with, that's what you would apply for, and then we will work through the process. And we will provide more information and tools to assist facilities in seeking designation, as well as understanding what level to apply for based on their certification or accreditation as we move forward and have more concrete processes related to that. Lastly, data. Data is a vital part of system function. Systems require collection of uniform and consistent data. The statewide registry allows for a holistic evaluation of stroke and STEMI care, just like we're doing with trauma. And we understand that there are a lot of questions related to data collection in the registries. Currently, the department is in the process of an RFP to contract a vendor for registry for all 3 systems, trauma, stroke, and STEMI. because that process is ongoing, there are still some details that we can't provide, but as soon as we have more concrete answers, we will start to disseminate that information. That being said, we can't stress enough the importance of a centralized data collection tool. Data is the system driver. Regions use data to drive system decision-making and evaluation. Regional professional review organizations use aggregate data to monitor regional care issues. System partners like EMS and facilities, rehab partners use data to improve care. And data drives risk reduction initiatives in the region and PI projects at the population health level for a greater impact. All that to say, system building takes time and thoughtful preparation. Rural and critical access hospitals are an important part of the system. We want everyone to participate. And the department will continue to communicate updated information and opportunities for participation as the system components are move forward. With that, are there any questions?
Hi, I jumped on a little late, so I apologize if you already discussed this, but was there an expected timeline of when designation may be starting?
No, we haven't. We have not set a specific timeline. We're still working on some components, and this underlying RFP for data is one of the components we need to be more concrete, more finalized before we can put a specific timeline on designation.
Thank you.
We'll, as Caitlin said, I want to just reinforce this. We will give programs plenty of time. Once we have established the criteria and the application process and everything else, you'll have plenty of time to submit, and we'll have all that process outlined.
Diane, I see your hand is raised.
Hi, yes, I actually have two questions. One is about, so the program is voluntary and inclusive, but what are the ramifications if an organization elects to not participate, to not seek designation?
Yeah, we get asked this a lot. As you can, so the purpose of categorizing your resources, it is particularly for time-dependent emergencies where time is muscle, brain, and the potential to bleed out, like for trauma, is to understand that you have the resources, and that to deliver a patient to a place that has the resources is really important. And I will tell you this, post-pandemic, the most efficient use of resources is now becoming absolutely critical. Our EMS workforce is stretched still. We're working hard to reinforce it as best as we possibly can, but taking somebody to a place who doesn't either have, TNK on the formulary, or their CT scanner is down, or they're just are on diversion more formally or more often, are the things that we need to understand. And if you don't have the resources to care for the patient is on the back of the rig with either trauma, stroke, or STEMI, then we want to know that so we can make a better destination decision. So that's a long-winded answer to, we need to know what your resources are so that we can deliver those patients appropriately. And also, I think I want to add one more point to that. We also want you as a building to understand where the next important full resource is. If you are, an acute stroke ready, and you need to understand who is going to, do some more neuro intervention, or where the neurosurgeon is he on staff? Is he's got his call schedule? If you move them to the next place, is that the most appropriate place? Systems work and regional work make that information much more visible, and that's the intention for systems.
Thanks, Eileen. And then my second question is just clarifying around, you said you're seeking a single vendor that would be for trauma, stroke, and STEMI. So is the expectation that we would all, like, we're already doing stroke with the guidelines. We already have a trauma registry and MT-QIP. So would we need to switch to the new vendor? Is that an expectation? Or is there a way to still get the data to you?
You want me to start, Caitlin?
Sure.
The RFP, the requirements for vendors to submit a proposal to us required them to describe their ability to integrate. So that is the expectation. The other requirement is that they have the front-facing view of the registry is similar to all three service lines. So in other words, you pull up a patient profile page and you want to enter a patient, and it's perhaps they were a trauma patient who had a stroke. You would see the exact same front-facing piece and sign-in piece for all three of those registries. You just go farther in to put your data in. So we want this to be as simple for you as possible. And the other thing is if you have a file, a CVS or a CSV file or something else, we want you to be able to submit that too. So that's the intention.
Right.
Yes.
Have not finished. The RFP is not complete. Go ahead, Caitlin. Did you want to add more to
Thanks,
that?
Eileen.
Just kind of reaffirming what you said, and that we've taken what we've learned from collecting data from the trauma side of things and how, data is collected to try to make sure that they can facilitate a process that isn't gonna that is going to integrate or allow you to file share, if that's, unless you're a small facility that's only adding a couple, and then we would support it in the same way that we currently do, which is, give you access to log in and do direct entry. So those are the things that are in the RFP that we're just waiting on an outcome so that we can see what it will actually look like and give you guys more information, a better understanding of what data collection will look like on the other side of this.
Currently, Trauma has 43 hospitals who use the registry as their software collection tool. They direct enter their patients into the registry, pull reports, use it for their PI, use like you would any other software program. And that is the intention. If that is what a facility would like to do, that we would provide that and continue to provide that without cost.
Great. Julia, if you'd like to go next, and then we have a couple of questions in the comments that we'll get to after Julia.
Yeah, sure. So I have a few. So to just make sure I'm clarifying the answer to Diane. So we do currently report stroke and STEMI both to AHA. So that basically the state's registry and AHA is going to be integrated together, is what I'm understanding. Am I hearing that right or no?
It depends on how you define integrate.
Okay. Like we would still plug in our data in AHA, and AHA would talk to the state, would feed that information to you guys.
The pathway
Those levels of we have not our RFP determined, and we haven't gotten to that far yet.
Okay, so because we're stroke certified with Joint Commission, and we've been collecting data for Heart Ready now for a year, and we're about to apply for Joint to come so we can become Heart Ready there. But I'm not sure if that's what we should be continuing to pursue, or if we should just be postponing and waiting to see what comes from the state. Like, should I still pursue becoming Heart Ready with Joint Commission and that be okay? Or am I going to have to completely pivot once the state determines more moving forward?
Nope, that's exactly what we want you to do. We want you to certification or accreditation through one of those national organizations, and then the designation process will be sharing with us that you have that, and then working through kind of, much like trauma does for the smaller facilities or even the big ones. And then you would, show us that you're meeting the Michigan criteria. We are not doing in-state verification for stroke and STEMI at this time. In the early stages. So we do want you to utilize those national organizations to certify or accredit your organization. And that's wonderful that you're seeking that. We are excited to see programs begin to come online that way. So
okay, perfect. Sounds good. And as far as our registry process goes between trauma, STEMI, and stroke, I will say AHA is a much more favorable program to use to plug our data in versus the trauma registry. I don't know if others feel that way or not, but that's how we feel. So if we were to move our stroke STEMI registry into a platform similar to trauma, it would be harder for us as far as feasibility goes, especially because we have so much more cardiac patients than we do stroke and trauma as a critical access hospital. So just some feedback, food for thought as you guys are working to develop.
Absolutely.
Yep.
And ease of use, integration, continuity across the different service lines. Those are all things that are a part of that conversation as we're developing the registry. And there will, we want to hear your feedback about what works, or, what your processes are, so we can understand it as we're making those decisions.
Thank you.
Great.
Thanks,
So
Julia.
I'll move to some of the comments. So Alex Calloway asked, if this becomes required, any idea how long of a notice hospitals will be provided to plan or implement? And does this designation affect where EMS will be bringing a patient?
Well, I think I covered that with my response to Diane. Destination determinations are based on understanding resources. And yes, we will give you lots of notice. So I don't think we can say that enough, is that, and we have had a lot of experience building up trauma or helping trauma programs develop, and tools, resources, toolkits, opportunities to chat with each other about what your best practices were when you built up your program. And, the value is you're confident and you have built a good, solid program. And that's our first important goal. So we want you to have the opportunity to do that. We have had a lot of success with trauma doing exactly that. We had 127 hospitals, which are all the acute care buildings in the state, commit to being trauma facilities and have programs. So there is a lot of experience in program building there. So I think that I cannot overstate that we want you to build a good, solid program that you're comfortable with, that delivers good quality care to stroke and STEMI patients. And we want to provide you as much assistance and tools as we can to help you do that. So it's not as much time as it is performance and a good, solid program.
Great. Another question from the comments is, financially, is the state looking at reimbursement for these very valid programs? If not, why?
There is a limit to the resources that we have and that we can provide. We have a small amount of support. The registry is going to be bigger than we have spent in the past. Commitment to resources. We also are going to hire some staff to lead some of these conversations and support. So that is going to be what we can commit to systems development.
This is more a comment than a question from Julia. She loves that the AHA gives hospitals recognition on their data, i.e. bronze awards. Though that they aren't heart certified yet, they still received an award, and it was great feedback for our nursing team. I hope that this won't be lost in the integration.
Oh, great comment. Yep. And we have done that in the past for trauma, and we'll put that on the list of on the to-do list.
Are there any additional questions for Caitlin and Eileen?
We're happy to hear from you.
Yes. Our contact information is, like I said, at the end of the slideshow. You're welcome to reach out to either of us via email or a phone call. We're happy to set up a Teams meeting if you need a few minutes to chat and get some clarification on things. I am currently drafting a first quarter update, so we will be sending out a broader update about the status of where things are at. So everybody's on the same page. That should, hopefully go out. Our goal is May. That's our goal. And the plan is to continue those regular communications so that everybody is clear on where we're at and it feels like we're being upfront and transparent, and like we said, giving everybody lots of time, and also announcing when there's opportunities for participation. And also, this last slide is a link to our website, is the first one. That's where the administrative rules are posted if you want to read them. The white paper is there, and there's the FAQs were updated at the end of 23, early 24, so they are current, and we are working on another round of updates to get more information in there. And then these are the 2 Sentinel papers around systems for stroke and STEMI, which gives a little bit more background, and they were published in AHA publications. But they are a good read. They talk about systems and why systems are important and how they work to improve outcomes. So thank you guys again for taking time out of your day to chat with us and ask these questions. We appreciate the engagement and the opportunity to share, and know that every time we sit down and have a conversation, we are talking about the vast differences across our state and what programs are challenged with, rural, urban, suburban. So we do want to take your perspective into consideration when we're working through these things.
If you have questions that you didn't want to actually, say out in this venue, please feel free to reach out to Caitlin or myself, and we'd be happy to have a conversation. And if you've got some suggestions as we continue to operationalize or think about operationalizing this systems, these 2 service lines, please feel free to share. We do really, even when we are ready to launch some things, or we think we've got a process in place, we've got paperwork ready, we almost never do it without having pilot tested what we have crafted with a couple of content experts. I'd say, if you had this, does it make sense to you? Could you read this and do what's written in here? So we will making sure that what we put together is something that makes sense, is eminently doable for anybody who had it. So we'll be tapping on a few shoulders.
Looks like a comment in here from Jen Anderson. She said she apologizes if this was already addressed, but is there an idea or a plan to be able to submit the data elements via a file transfer versus manual entry into the registry?
Yep.
Yes.
That's a yep.
Certainly
But
makes life easier.
Yes, that's the goal. Again, I and I will not apologize, but we were not expecting that we would be, so the RFP, I guess, for a little bit more descriptors, is a request for proposals for all of the IT projects that EMS and systems of care do. So it is the licensing applications for all EMS providers, is the education and compliance piece for all EMS education EMS providers, and it's the 3 registries. So it's a large, and they all expired, the contracts all expired at the same time. We've had the same vendor for 10 years. It was a 5-year contract with 5 1-year extensions, and it was end of life. And end of life just happened to have occurred at the exact same time that the administrative rules, which we didn't really have control over in terms of when they were approved, it all ended up happening at the same time. So this is not how Caitlin and I intended to operationalize this system. However, it is what it is. And I do want to make one more, a little explanation. We mentioned the Michigan criteria a couple of times, and Michigan criteria is designed to help support this a little bit of the regional work that we do. So we want all the facilities who are designated in Michigan to work on a risk prevention project regionally, because sometimes that has a more population effect than doing it one building at a time. And then we also want the buildings to participate in regional performance improvement. And again, this is later on. This is not expected right this minute, but to think about to involve yourself in the regional work. Did the patients get transferred appropriately? Did they did they, was the pre-hospital care exactly as expected? If not, is this a system problem? Is this something we should all collectively talk about in our piece of geography? So that is the a brief description of the Michigan criteria and on how that would look and what your participation should be or what you need to think about it when it is time to do that. We'll make sure that there's a lot of guidance around that.
Great. Are there any additional questions for Caitlin and Eileen? If not, then we will give you back some time in your day. I know it's valuable. I did want to let everyone know that this has been recorded. It will be on the Michigan Center for Rural Health's website here within the next week, as well as a slide you are currently viewing. If you have any questions or concerns, please, again, feel free to reach out to Eileen, Caitlin, or myself. We will be happy to answer any questions that you may have. Please also stay tuned for a brief survey that will be sent out this afternoon. And everybody have a great and enjoyable Friday afternoon. Thanks for participating.
Thanks for having us.
Yeah, you're
Thank you.
welcome. All right,
Thank
thanks,
you.
everyone. All right, have a great afternoon.